All right, guys, let's get into trauma. I've got a fair warning. This might have some um, pictures you might not necessarily enjoy. I want to go back to this one. Trauma, we have to understand the mechanism of injury, and this is where we kind of raise these high level of suspicion about what's going on. So if you can kind of imagine what happens during the injury, you can kind of imagine what happens inside the body as well. And we can formulate plans based on that. So let's define a trauma. It's an injury resulting from energy transferred from the environment to human tissue. And they can occur in various ways, such as unintentional or intentional. We'll talk about the rest here in just a minute. And let me just kind of tell you about some facts here about our injuries. Injuries or traumas, the leading cause of death and disability for the people of Washington State. We are not unlike everywhere else in the nation, and is the leading cause ages 1 to 44. And in fact, it kills more Americans ages 1 through 44 than all other diseases in that subset combined, or that population combined. Injuries occur in highly predictable patterns with recognizable risk factors among identifiable populations. So in other words, we can try our very best to prevent these from happening, such as wearing our seatbelts, putting ourselves and our children into car seats, and wearing hard hats while we're at construction sites, things like that. And this was just an annual visits, ER visits, is right up about 41 million in the United States yearly. Yikes. I took some information from Washington State Department of Health and created a table for you guys to see just what this injury or trauma or how we're dying looks like in Washington State. So I would definitely consider unintentional injuries, suicide, and homicide. So unintentional and intentional traumas to be very, very high there, especially like we had just said in the last slide, in our ages 1 through 44 year olds. So high levels there. And then after 45, we start considering some malignancies, cardiovascular disease, things like that might end a person's life. But definitely it's going to be those unintentional injuries that are going to end the life of our 1 through 44-year-olds. So Washington State Department of Health provides a designation for trauma leveling, and this is how well a hospital can support a trauma. Level 1 is the highest level of acuity, and level 5 would be like our lowest level of acuity, sort of like our, tertiary emergency departments in rural areas, things like that. So here locally, we have our, Catholic, our trios, and our lords. Just right here in the Tri-Cities, Catholic and trios are designated level 3, so right there in the middle. And lords would be designated a level 4. And so let's say a level 1 has to have a teaching hospital within it. It has to have 24-hour ocular care, ophthalmologist type specialties. They have to have neurosurgeons that are on 24 hours a day, things like that. But it's really hard to get these designations raised. Can anyone guess how many level 1 trauma centers are in Washington State? And the answer is 1. It's Harborview Medical Center in Seattle there. So to understand a mechanism of injury, we need to consider a couple of laws, but the ability to understand these, like I had previously mentioned, enables us to maintain a high index of suspicion and allow us to predict and locate injuries quickly to save lives. So we have this Newton's first law of motion. So it says, I don't know if you remember, high school chemistry or wherever you first heard this, but a body in motion remains in motion at the same velocity until it is acted upon by an outside force. Kinetic energy equals half mass times volume or velocity squared, So in simple terms, the velocity of an object has a much greater effect on its kinetic energy than the mass. So we care about speed, right? Simple terms, the faster the car goes, the worse the outcome. I invite you guys to watch this YouTube video about mechanism of injury. It is actually a commercial about wearing your seatbelt in Europe. They must not have as many violence laws in Europe because it is kind of a violent one. But at the end of the day, it kind of makes the person think about what is getting hit and at what force and how we can predict these injuries by the time they get to the emergency department. And unfortunately, this fella ran into a saw. Yikes. So like we had mentioned, we have these mechanisms of injury. We'll go into penetrating injury, gunshot wounds, stab wounds, and we'll go into blunt trauma, motor vehicle crashes, or you'll also see it in VA, motor vehicle accident, and pedestrian injuries. And then we'll go into blast injuries, but we'll talk about drowning and aka suffocation and asphyxia at a later date when we talk about our environmental emergencies. So, based on what we know about mechanism of injury, what can we predict this little piggy might come to the hospital with? I'm going to say a blunt force trauma to the head by a mailbox or a car going in the opposite direction. We should not be sticking our heads out the window. Okay, so penetrating injuries. This is an injury caused by objects in motion that penetrate the body. Energy created by the object dissipates into that surrounding tissue. So the surrounding tissue takes force or energy from that. The extent of the injury depends on the characteristic of the wounding instrument, whether it be a knife or penetrating object or a gunshot wound, and it also depends on the velocity at the time of the impact or the amount of energy transferred to the human host and characteristic of tissue in which it passes. So where is it happening? What's going on underneath on our body? So penetrating injuries are stab wounds. They actually carry with them a better prognosis than our gunshot wounds, and that's because there's more localized injury. So the tissue damage depends upon the length and width of the object. Nothing more than that. But obviously the location at which a person was penetrated affects the severity of the injury. And then our gunshot wounds, we have our entrance wounds, and we may or may not have an exit wound. By the way, when we're charting, we chart wounds as wounds. We don't say the entrance wound was this large and the exit wound was this large because we are not forensic scientists and we have not had specialized training to determine that. And in fact, most emergency physicians are not either. We just chart wounds as wounds. So one wound that was on this part of the body was this big and looks like this, and the other part of the wound that was on this side of the body looks like this. We don't care to guess entrance and exit wounds. And then the caliber and velocity of the weapon are directly related to the extent of injury, and damage occurs from bullets and speed at which those bullets travel. So if you don't know much about bullets, some travel a little bit slower and some travel faster. They're designed to do that. And then they vary greatly on size and they vary greatly on their tips. So this kind of shows you what happens to a bullet once it kind of hits tissue. Some of them are meant to explode out and create all this mass chaos type shrapnel, and then some are meant to be more slugs. bigger thuds. When we take our history of a gunshot wound, we need to note some things. We need to know how far away the person or the patient was from the shot, what kind of bullet gauge there was. In this case, we've got shotgun pellets, how many numbers of the number of shots fired, the weapon that was used, and the time of injury. And I've actually I've actually seen a gunshot or a shotgun shot to the chest, and luckily it was all superficial, which it kind of looks like that's what this is going on here in this x-ray, because you can see those like little pellets that are floating on the right, and that makes me think that they're more in the superficial tissue, the dermal layers, as opposed to those big structures that we care about, like the heart and lungs. Okay, as far as blunt traumas go, a blunt trauma is an injury with no opening in the skin or communication to the outside environment. So it's not open. The extent of injuries is not always obvious. We cannot see what's going on inside that body right away. But they're obviously just as life-threatening as our external injuries. And these are caused by all sorts of things. Motor vehicle crashes, farm equipment. We have a lot of farm equipment stuff, conveyor belts, injuries, things like that come into the emergency department. And bicycles, falls off of roofs and things of that nature, assaults, and sports or recreation related injuries there. A lot of four-wheeler injuries. So blunt trauma, the energy patterns causing blunt trauma, and these are really just to the head here. So we have our acceleration, deceleration force. We're going upon an accelerated speed, and all of a sudden the energy is transferred by something blunt. So we all of a sudden stop there. And then we have rotational force issues, such as our hyperflexion, hyperextension, and this is what we'll call that whiplash, and you'll get oftentimes that contra coup type injury where you're hitting or you're injuring like not only the side of the head that got injured, but also the very opposite of that. Then we have our axial loading, which is a force from the very top of the head. Shearing is in a sheared type state. We are losing gray matter from our skull there. And then compressive or squishing type forces there. So our low density and porous tissues and structures, such as our hollow organs like our lungs and our stomach, usually sustain less damage due to their elasticity. So I like to say, is it a cube or is it a tube? In this case, tubes would be our lungs and our stomach, something that's open to air, and those are more elastic. Our cubes, such as our heart, spleen, and our liver, are less resilient and will oftentimes endure some damage. And just like I had said in a previous slide, our external signs of blunt trauma are oftentimes not really readily apparent. So once again, we just go back to that mechanism of injury, how it happened. So we do need to take some notes as a nurse, and we need to ask ourselves or ask the patient or EMS or a witness to what happened. What was the length of the fall? Was there, where was the person sitting in an automobile? Were they in the back? Were they the driver? Where was the location of impact on the vehicle? How long did it take the EMS and fire services to remove the patient from the vehicle? They call that extrication time. Was the person ejected from the vehicle? Did airbags deploy? Was the person restrained? Did they have a seatbelt on? Did they have a helmet? And what were the speed of the vehicle that the they were driving in and the speed of the vehicle that the offending car was driving in. We have to think about those laws, right? Newton's law. And whether there was any other occupants, just like in that video you guys are going to watch of that commercial where there was other occupants, and were there any fatalities? Talk a little bit about crush injury. What we need to, we'll talk about these a little bit more in depth, but we do need to know that these can easily result in traumatic rhabdomyolysis. A person can easily go into kidney failure with rhabdo, and so we take this very seriously. One of our labs that we'll get on this patient is going to be a CK level to see if it's 5 times the normal limit, then the person's probably, is in rhabdomyolysis, and we should be giving them lots of fluids to protect their little kidneys there. So causes of that, motor vehicle crashes, lots of industrial stuff, like I said, the conveyor belts, forklifts, I've seen it all. And then like building collapses. We'll talk about a little bit more on treatment at a later slide there, or basically a later lecture. And I do want to talk about blast injuries. So these are caused by like explosions such as gas, propane, etc., fireworks, or IEDs, or improvised explosive devices. You'll see that oftentimes used during wartime. And the impact occurs at 3 phases. So this is kind of interesting to know. The primary phase happens when a blast creates this pressure wave, and the organs containing gases are most affected by this pressure wave. So our tubes, and these would be our lungs, our intestines, ears, stomach. During our secondary phase, you're going to get some flying debris, and you will get an injury based on as a result of blast force. There's lots of injuries that can occur during this phase, including penetrating injuries, lacerations, burns, etc. And then tertiary phase, which is the force of the blast, causes the human to fly backwards, creating an injury to the site of impact or where they hit after they fell backwards. And let's dig into a trauma. This probably is like making the heads and hearts hurt of our future ICU nurses here, but it's very easy to make a room look like this in absolutely no time at all. And it looks like lots of good interventions were done for this patient. As you can see on their level 1, we'll talk about that. This is in the right upper corner there that says 1. There's blood hanging, so the person got blood products. Looks like there was some forensic evidence that was collected on that left side. I can't really say about the stuff that's on the ground there, but it looks like they started at least a central line and perhaps maybe even an art line and intubated the patient while they were there. So lots of stuff happened in a small amount of time, but we're going to break it up into kind of step-by-step guide. So our trauma assessment goals are we're going to be recognizing life-threatening injuries and conditions. One of the ways we could do that is determining mechanism of injury, right? We're going to identify all injuries. That's our goal, and it's part of EMTALA's strategy there. And we're going to determine the priorities of care for the trauma patient. So each ER has their own criteria for and procedures for a trauma team activation based on their own hospital resources. And the pathway puts the players in place in a timely manner, ideal prior to the patient's arrival. So we will often get a trauma that's called out in the field. We have a trauma coming in. We call the trauma out, and all the players from different areas of the hospital come down and see us. And over here on your left, you'll see one particular hospital's criteria for trauma designation. So things to consider with our trauma activations, our mechanism of injury, the signs and symptoms that the patient is exhibiting, the age of the patient, and the propensity of the patient to bleed. In other words, sometimes they call traumas on head injuries. A patient, even at a ground level fall if they're on blood thinning medications. Lots of things to consider. So there's roles of the nurses in the team, and we go through A, B, C, D, E, F, G, H, I, J. So we're going to go through all of these. The first thing we need to do is prepare the room and make sure all of our players are in place. Then we'll do the primary survey, which is our A's, B's, and C's, and D's and E's, and then do some resuscitation adjuncts, which is F's and G's. Then we're going to reevaluate the patient. Then we'll perform a secondary survey, reevaluate, and J, which is our keep evaluating, just keep evaluating, and post-resuscitation care. And then at the end of this, we will create a definitive care plan or transfer plan. So in that preparation mode, prior to the patient's arrival, the team will do all of these things. We're going to call an activation. We're going to gather our supplies. That may be PPE, blood, whatever we think that we need or whatever gets called out to us. Then we're going to share what we know. So everybody on the team knows exactly what to anticipate as far as mechanism of injury is concerned. We're going to prepare that room. We're going to put on our PPE. And then oftentimes the hospitals will arrive the patient in the EMR prior to the patient coming. So we're able to, if we do have information on this patient, know what their allergies are. Otherwise, we arrive them as anonymous people so we can get our all of our ducks in order for them, and they come in as an anonymous patient. And then we figure out a game plan. I have airway, you have breathing, you have circulation, you'll start this IV, all of that. Okay, so A stands for across the room assessment. So what do we see right at the time the patient comes into the room? And then we care about their airway and alertness. First, we also take a top priority for cervical spine immobilization. If the patient does not have a cervical spine immobilization, then we should put a C-collar on that patient. Otherwise, we keep their cervical spine as straight as we possibly can, so somebody supports that at all times. B stands for breathing and ventilation. C will stand for circulation and control of hemorrhage. And as you can, we'll see here in a minute, sometimes that control of hemorrhage takes place in that A category there. So we could do C, A, B, C, if we have like this overt hemorrhage that needs to be taken care of right away. And then disability stands for, or D stands for our disability. I'll tell you a little bit about AVPU. We also use the Glasgow Coma Scale, which you guys have learned extensively with Sarah. E stands for exposure, so we will make sure that the clothes are cut off of that patient so we get a good look at them, and environmental control. F stands for full set of vital signs and family presence. G stands for get monitoring devices and give comfort. Sometimes they call them gadgets. We'll talk about that here in a minute. H, this is getting into our secondary survey is what they call it. So we take the patient's history and then do a head-to-toe assessment. I stands for inspect their posterior surfaces, so look at their back. And J, just keep reevaluating. Those are the mnemonics that they use. So let's talk about the across the room observation. Uncontrolled hemorrhage is a major cause of preventable death after injury. Therefore, we take top priority if there is an uncontrolled hemorrhage. So upon arrival, the team can reorganize that priority from ABC to CABC, or controlling that hemorrhage first. So our first priority then is to treat the greatest threat, and in some cases it's that controlled hemorrhage. Otherwise, we'll continue on with A. This is that cervical spine immobilization. This is sometimes what it'll look like. They are doing lots of research and evidence-based practice here locally, and we are almost exclusively not using hard backboards because they are creating more harm than good for these patients. So you'll see a patient on the soft board. Otherwise, they are immobilized with their cervical spine. So airway and alertness. Is the patient alert and can they speak? And AVPU is just like the most basic thing that we can do. If they're alert and can speak, then they're alert. If they're if it's verbal, then they respond to verbal stimuli. If we give them a P, then they respond to painful stimuli, and the patient is unresponsive. So are they alert, respond to verbal stimuli, pain stimuli, or unresponsive? Kind of just like as easy as it gets right there to determine a level of alertness. And can the patient open and protect their airway? If the patient is unable to open the airway, we use our jaw thrust. So quickly, we are going to inspect the patient for a tongue obstruction, loose teeth, foreign objects, blood, vomitous secretions, edema, burns, tracheal deviation, and do a quick auscultation of any kind of obstructive airway sounds. Palpate quickly for a bone deformity, and if a definitive airway is in place, we're going to assess for placement and securing devices. So make sure that it's going to stay right where we want it, and then continue on with the assessment. So this is a quick one. Do they have anything that's obstructing their airway? If they don't, we move on. If they do, then we perform measures for them. So if the airway is patent, move on to B, breathing. If the airway is not patent, then we'll do some measures for them. We're going to manually open that airway. We're going to suction them as needed. We'll do a finger sweep. We're going to remove any kind of debris that might interfere with their airway. And we might add a airway adjunct, such as oropharyngeal or nasopharyngeal airway. And then more definitive airways, such as our intubation there. And then we reassess. If their airway becomes patent after all these interventions, then we can move on. If it doesn't, we stay on A. B is for breathing. Okay. For these breathing guys, we're going to inspect the patient for spontaneous breathing. We're going to inspect for symmetrical rise and fall of the chest. We're going to look for depth, pattern, and rate of respirations. We're going to look for any signs of respiratory difficulty. We're going to take a look at the patient's skin color, and we might look for any wounds, contusions, abrasions, or deformity that's causing this patient to not be able to take a large ventilation. So, for instance, if a person had a burn, it may be difficult for them to take a breath based on their burns. Quickly here, we're going to auscultate for breath sounds, presence of breath sounds, quality of breath sounds, bilateralness, or if they're occurring bilaterally. We're going to assess for heart sounds and palpate for bony structures, any kind of subcutaneous emphysema. So when you kind of push on the person's chest, are you feeling any Rice Krispies underneath there, or any kind of soft tissue injuries that's going to, like I said, prevent the patient from being able to breathe and ventilate on their own. And if breathing is present, then we can move on to C, right? If it is not present, then we do something until it is present. and go right on back through there until we've fixed that situation. So if the breathing is present, another thing that we do for these people is administer oxygen. So we'll often put a non-breather mask at 15 mils a minute, so or less. We can go usually as low as 8 before a non-rebreather mask doesn't make any sense anymore. And I've provided an article about hyperoxemia and why we should try to avoid getting that patient up to 100%. I really suggest that you look at that. And then we determine the ventilation effectiveness. We can use some tools in our tool bag. One of those is Entitle CO2 monitoring, which is a really great one. You guys get to tell me what appropriate Entitle CO2 is. 35 to 45. All right, so breathing and ventilation continued. If ventilation is ineffective, we're going to breathe for them. So we're going to assist with ventilations with the valve mask. And typically we deliver 10 to 12 breaths a minute. Keeping that oxygen at 15 liters a minute on our non-rebreather, or prepare for a definitive airway. And then we need to identify and then treat life-threatening thoracic injuries. If these are all effective, we move on. C stands for circulation and control of hemorrhage. So in regards to hemorrhage, this is the leading cause of preventable death after injury. So we should be taking note of hemorrhages. This is why we check it so many times. We do a continued assessment and high index of suspicion at all of these stages of the game for control of hemorrhage. So that across the room observation, wow, they're bleeding, we need to stop that. That primary survey, so at C, circulation control of hemorrhage, this is where we do it also, right here, right now. And then reevaluation directly following the primary surveys, we go back and take a look at the C, the hemorrhaging, and then reevaluation following the second survey. So we're constantly looking and making sure that the patient doesn't have an uncontrolled bleed that we need to control. So we're going to inspect for uncontrolled external hemorrhage, skin color, and then we're going to palpate for presence and quality of central pulses. Those would be our femoral pulses, right? And then palpate for skin temperature and moisture to see if we are adequately perfusing there. So if the pulses are absent, then we do not move on further. We initiate basic life support. We're going to assess and attempt to treat the cause, such as perhaps an uncontrolled internal or an external hemorrhage, and then we're going to assess for potential causes. So we might want to consider the mechanism of injury. I highly recommend it. If the pulses are present, do we need to make sure that the circulation is effective? Yes, we do. We're going to inspect again for external hemorrhage, skin color, palpate for central pulses, the rate, rhythm, temperature, moisture. Are all these effective? If circulation is ineffective, then we're going to assess for signs of uncontrolled hemorrhage. Wow, look at me saying that again. And then interventions as necessary. So you guys get to guess what traumatic event causes the most internal bleeding, and I will tell you at a later date. Okay, circulation and control of hemorrhage. To control that hemorrhage, since we've talked about it so much, how are we going to do it? Sometimes it's just as easy as applying direct pressure. We also want to elevate the hemorrhage extremity if it's happening at an extremity, elevated above the heart. So we're giving it its best shot at being controlled. And then we may want to apply pressure over a more peripheral arterial site and consider a tourniquet. I have to tell you guys about tourniquets. They've kind of come in and out and then back in favor. They're in favor at the moment because just like I had said in the previous slide, hemorrhaging is a high fatal, high or carries with it a high fatality rate. So if we can control a hemorrhage, we would rather lose an extremity than a life. So those really have kind of come back into favor. And hopefully one of your friends gets to talk to you about tourniquets. I can't wait to hear it. Okay, so other things we can do once we have controlled hemorrhage and the person has effective circulation. So we've checked those central pulses. There's good rate and rhythm going on. Then we can cannulate 2 large bore IVs, and this is usually a 18 gauge or greater. And then initiate an infusion of a warmed isotonic crystalloid solution. We make sure it's nice and warm because we don't want the patient to experience any kind of hypothermia, which can really happen during these trauma events. And a warm patient carries with it a higher level of, or a higher prognosis. So everything we need to do for them, it needs to be warm blankets and a bear hugger if needed, keep them nice and warm. So an isotonic crystalloid solution, lactated ringers or normal saline. We're going to use blood administration tubing in case we need to give blood. We're going to obtain a sample for them for type and cross match if not, and they are in need of blood, because we should really be replacing blood with blood. Then we give O negative, which everybody can is happy to accept. We might consider a rapid infusion device, which one of your peers is going to be talking about as well, and then intervene in any kind of life-threatening situations. D, or disability, aka neurostatus. For these guys, we're going to quickly inspect the pupils, check for pearla. We're going to assess the Glasgow Coma Scale. And I just, you probably have gone over this a little bit in your neuro lectures, so I won't beat you to death with that. So as far as disability goes, we need to consider at this point getting a head CT for that person that's less than alert or has a lower GCS. We're going to consider arterial blood gases, what's going on arterially with the blood, and then consider a glucose there. And the picture on the right is a example of a subdermal hematoma with a midline shift, and midline shifts usually are very bad things. We do know that's a bad CT right there. Exposure and environmental control. So we're going to assess them by removing all clothing, and maybe you'll see some uncontrolled bleeding that you hadn't before now that you've gotten them exposed, and then note any kind of obvious injuries. And then do some interventions such as perhaps maybe some evidence collection, keep the patient warm, and assess cord temperature. So we use like rectal thermometer, esophageal thermometer, or Foley catheter. We'll use a thermometer there. When we do evidence collection or preservations, we don't delay care to preserve evidence. But if we can, we'll put all clothing in a paper bag. We don't wash the hands of the patient with a gunshot wound. There might be some forensically important things on their hands. And then we cut around bullet holes when we go through clothing. We also go through or cut around powder burns, knife cuts, and clothing. We don't cut right through them. F stands for full set of vitals and family presence. And in the case of this fella who doesn't really look like he's got a great prognosis neurologically, his family is his little dog there. And so full set of vitals mean we take a full set of vital signs, baseline vitals, and then obviously we're going to watch for trends, for changes, keeping all of these things in mind, all of the vital signs in mind, and then facilitate that family presence. You guys have all gone through mental health with me, so you know how important family presence is in this, and we might utilize that chaplain or another liaison or advocate for the patient, and we support the family being in the room when we resuscitate the patient. As far as G goes, we're going to do gadgets and give comfort. As far as gadgets go, we think LMNOP. So L, laboratory studies. We might take labs from these people. M is monitor their cardiac rate and rhythm. And then we'll also obtain an EKG from that patient. We're going to go for N, which is naso or gastric tube consideration. And we want to make that stomach nice and compressed, so we're not dealing with extra air as we intubate the patient. And then O, we're going to consider their oxygenation and ventilation analysis there. And P, we're going to assess their pain and pain management. And then G also stands for give comfort. So we will do a pharmacologic or non-pharmacologic intervention. So now, after all of that, the primary assessment is complete. And we went through it in a nice systemic fashion, but when you see it happen in real time, these are all kind of happening at once. I do appreciate the doctor, and I will ask the provider, especially when I have a new trainee, to go through A's, B's, and C's to kind of shout out what that looks like. A, their airway is intact. B, they're breathing, they're ventilating well, their respirations are at 18. But like I said, it all happens all at once. It's really nice to think that we go A's, B's, and C's, in a row, but we don't have time for that. We might as well use our resources there. Okay, so reevaluation. After the primary assessment, now we do a reevaluation. This happens where we might get a radiography of the patient or do a fast exam. So that's going to be the bedside ultrasound to see if any fluid is where it shouldn't be. And as you can see here in this picture, there's some free fluid at the spleen. There's likely have a splenic rupture there with some blood in the spleen or outside of the spleen. Free fluid, and we're going to determine a need for the patient transfer and prepare the patient for transfer if that's what we're going to do, or keep them at the hospital. Okay, so history and a head-to-toe assessment. We might get a pre-hospital report that's going to help us out with the history of the patient, and with that, we are going to do something that they call MIST, or they'll call it mechanism of injury. They're going to call it, or they're going to tell you, what kind of injuries are sustained, and go over the signs and symptoms with the patient, and then also the treatment that they have done so far. You might also see the EMS use something called SAMPLE. So that stands for symptoms, or the patient's kind of chief complaint, like what's going on with them, what kind of allergies they might have. That stands for the A part. Medications that they may already be taking is the M. P stands for past medical history, what else they have going on medically. And L stands for last oral intake. E stands for the events, like what was happening leading up to the injury. And then we do a thorough head-to-toe assessment. We're going to use all 5 of our senses and document the findings. So we're going to look at the head and face. We're going to check soft tissue, body injuries, wounds, if there's any kind of edema going on, ecchymosis, asymmetry. We're going to know all of those. We're going to palpate for tenderness, step-offs. We're going to feel for any crepitus, that kind of crunchy feeling. We're going to look at the eyes. Do they have a gross visual acuity? We're going to look at pupils, any kind of extraocular movements that are happening. We're going to look at their ears. Is there drainage coming out of their ears? Is there bruising at the ears? Is there any wounds to the ears? We're going to look at the nose. We're going to look at the nasal septum position. We're going to look for any bony deformities. We're going to look for any drainage. We can actually assess for drainage of cerebrospinal fluid in the nose too. So we look at that. What does drainage look like? We are going to maintain their cervical spine precautions until they're cleared by the physician, but we can look at the wound with their C-collar on. We'll note any kind of or look at their neck with their C-collar on. We'll look for any wounds, edema, contusions. We're going to assess the tracheal positioning. So a deviation from midline on the tracheal positioning could be a sign of attention pneumo. And then we're going to assess for jugular vein distension. We look at the chest, the respiratory rate, depth, effort, and then we're going to assess for wounds, ecchymosis, edema, listen to breath and heart sounds, palpate for crepitus, all these things that we do in a head-to-toe assessment with the addition of looking at wounds. We're going to look at the abdomen and flanks. Note any wounds, ecchymosis, pain, if there's bowel sounds, if there's any pain going on there. We want to check the pelvis for stability. We do very gentle pressure over the iliac crest and then gentle pressure on the symphysis pubis. I will show you guys how to do what they call an open book with these patients, but if there's any kind of level of suspicion for a pelvic fracture, we don't want to perform these maneuvers. We just want to stabilize the pelvis because we can create further injury for these patients. And then the perineum, we're going to look at any kind of blood in at the meatus site or note any kind of priapism, which could be indicative of neuro issues there. We're going to also look at the extremities. We will look for any kind of soft tissue damage. We're going to assess temperature, moisture, evidence of pulses, neurovascular status, circulation, sensory function, motor function, right? CSMs. We've gone through that once or twice so far in nursing school. And then inspect those posterior surfaces. We want to log roll the patient. Note the person up at the head is keeping an eye on the person's cervical spine there. And they are the ones that are in charge of the log roll. So at their command, we will turn to the right or put them back on their back. But the person that's at the head is in charge. We're going to inspect for blood, edema, and wounds on the back, palpate for deformities or tenderness. We're going to note rectal tone, which is that ability to squeeze gluteal muscles, which can give us some indication about how well the patient's neurostatus is doing. And then consider removal of that rigid backboard. Like I just explained, we almost never use those anymore. So if it's not there, we don't have to remove it. Then we're going to reevaluate or utilize reevaluation adjuncts. So we did the H and I, and now the secondary survey is complete. So at this point in time, we can do more things as needed. Radiographs, we might consider CT, angiography, MRI for that patient. We're going to do some lab studies if we haven't already. Perform some wound care. Patient, if they have a deformity in their extremity, we might want to apply some splints to those. We will provide that patient with a tetanus booster, antibiotics as necessary, sedation, pain relief, all of these things. Bronchoscopy might be needed or surgery might be needed for these patients. And then J is just keep reevaluating. And now we are done, almost. And just keep reevaluating. We're going to evaluate interventions, neurostatus, vital signs, pain level, and then do a primary and secondary assessment as needed. And as far as definitive care goes, are we going to send the patient away to a higher level of care, or is the hospital that I'm working at going to be able to provide the services for this patient? Can my hospital handle this patient? What laws do I consider for transport? I'm going to go ahead and say EMTALA, right? And what is the best way to transport? And this depends on all sorts of things, such as the weather and availability and how far the transportation is. And that, my friends, is the end of this lecture. Aren't you glad we broke it down into two? Whew!